Thank you for joining us, and good morning, good afternoon, and good evening to you all. So my name is Karen Hind, and I am the Director of Clinical Affairs at Medimaps Group. And it is my pleasure today to host this webinar on reimbursement on trabecular bone score in the US. So let's start. It's my pleasure to introduce you to my co-presenters. Michael Beebe is an Executive VP at Advent Health, a consultancy specialized in coding and reimbursement. He has extensive experience with public and commercial coding, with payment policies and practices. He also has in-depth knowledge of process for maintaining the CPT codes and the Medicare physician fee schedule. Previously, Michael spent 14 years at the American Medical Association covering the CPT codes RVS and RUC. Today, Michael will be presenting on the Medicare reimbursement for TBS in 2023. Dr. Lauren Nicola is a leading radiologist and the CEO of Triad Radiology Associates in Winston-Salem in North Carolina. She is a national health policy expert, holding numerous leadership positions, including in the American College of Radiology. Dr. Nicola has been instrumental in the creation and valuation of multiple new imaging and AI codes. She has published numerous peer-reviewed articles and is a prominent speaker on topics of health policy and reimbursements. Dr. Nicola will be presenting on the TBS reimbursement in real-world practice with helpful do's and don'ts. So before we move on to the reimbursement focus of this webinar, I am first going to provide some context on the clinical relevance and application of trabecular bone score. So despite numerous preventative efforts, osteoporosis continues to present an escalating burden to patients and to healthcare systems. This highly prevalent disease affects over 1/3 of women and 1/5 of men over the age of 50. The subsequent impact of fragility fracture is both widespread and severe, with over 2 million cases annually in the US alone. These fractures not only represent a substantial financial burden, costing the US healthcare system over $18 billion each year, but they also result in considerable pain, suffering, and disability for patients. Despite the availability of effective anti-osteoporosis therapies that have been proven to reduce fracture risk by 40 to 70%, we face a significant challenge. These therapies are considerably underutilized, leading to what is known as the treatment gap. In the US, this treatment gap is around 72%, and this calls us to a critical task to ensure that these treatments can reach the patients who need them. One key strategy to address this treatment gap is improving the fracture risk assessment. By doing so, we can identify more patients to ensure that they receive the treatment that they need. So we can move to look towards the definition of osteoporosis, which most of you will be aware of. And osteoporosis is defined as a systemic skeletal disease characterized by low bone mass and a microarchitectural deterioration of bone tissue, which leads to the subsequent fracture. We know that DEXA can be used to assess bone mineral density, and that cut point of osteoporosis is a T-score of -2.5 or less. However, a key problem and a key clinical challenge is that 40 to 50% of patients who fracture are not osteoporotic based on BMD alone. And the chart on this slide illustrates that the fragility fracture rate in women and the absolute number of women who will go to sustain a fracture. And you can see from this chart that fracture rate increases exponentially with reducing BMD. However, you can also see that in terms of absolute numbers of women who fracture, there are more women who will fracture who have a BMD T-score in that osteopenic range. Prior to fracture, these women would not usually reach the intervention threshold to enable them to be identified for treatment, and therefore these patients would be missed. Now let's focus on the second aspect of the definition of osteoporosis, which is the microarchitectural deterioration of bone tissue. Low bone mass is measured, as a reminder, with the bone density, but what about the microarchitectural deterioration? The solution to that challenge is bone microarchitecture as assessed by trabecular bone score. And this is an index that has been validated in numerous studies in the scientific literature going back over a decade. And the TBS can be measured and can be assessed and interpreted as degraded, partially degraded, or normal. So in the three categories, just as you would with BMD, as normal BMD, osteopenia, and osteoporosis. TBS, in addition to BMD, helps to identify up to 30% more patients at risk of fracture who would not have been detected by BMD alone. Now, this is significant when we think about that treatment gap. With the confidence of the TBS, we have the knowledge that TBS is underpinned by over 1,000 clinical studies and is incorporated into over 30 clinical guidelines, including the IOF and the ISCD. A good example is to think that you may have two patients present with you, and these two patients can have a similar BMD, but in actual fact, they can have a different TBS. And with that different TBS might lead to a different outcome for that patient. Here is an example with patients of two patients with a similar BMD, a BMD on the top and then the BMD patient at the bottom. And then you've got two examples of different bone microarchitecture. The patient at the top has a good microarchitecture, and you can see that from the variogram, and you can see that from the outcome TBS image. Now, the patient underneath has a poor bone microarchitecture, and we can see that through the image as well, you can see more of a red in that area on the color map. This patient on the bottom is at a greater risk of fragility fracture than the patient on the top. Had this patient only received a BMD measurement, that patient might not have been recognized as being at high risk of fracture. The higher TBS will correlate with a better bone microarchitecture, and the lower TBS correlates with a worse microarchitecture. So what about the guidelines? I really wanted just to emphasize the new guidelines that have been published by the ESCEO and the International Osteoporosis Federation under the auspices of the WHO Collaborating Center of Epidemiology of Musculoskeletal Health and Aging. This is a recent paper just published on the 1st of July, actually, this month. And it's all based on the update on the clinical use of TBS and the management of osteoporosis. If you need some guidance, if you'd like some more information in terms of the clinical evidence underpinning the use of TBS, then this is the paper to go to. Just to summarize quickly, we have three key areas of expert guidance. The first is primary osteoporosis, in that there's confirmation about TBS's ability to predict fracture independent of BMD and clinical risk factors. And just clarifying that clinical value for fracture outcomes, and emphasizing again that the greatest utility is for those patients who are very close to that intervention threshold, so those in the osteopenic group. There's also a section on the expert guidance for the use of TBS in secondary osteoporosis. We know TBS predicts fracture associated with type 2 diabetes, chronic kidney disease, etc. And then we have a section on patient response to treatment, which is pretty important and a step forward, in that the TBS can be used for both initiating treatment and for monitoring treatment in patients. And finally, just to sum this up, what does this look like in terms of your clinical practice, and what would the reports look like? This is just a quick overview as to what you might see. We first, on the left, will see an overall bone health assessment, whereby the BMD T-score and the TBS category is illustrated nicely in a matrix. You see the different levels of fracture risk there. Then you can also have the option to adjust the BMD T-score for TBS and the FRAX adjusted for TBS. And these are the typical reports that you would see. So that's a quick overview from me in terms of the utility of TBS in clinical practice. And I'm very happy now to hand over to Michael Beebe, who will present on Medicare reimbursement in 2023. Over to you, Michael.
Great. Thank you for having me today. It's a pleasure to talk with you all. You can go to the next slide. All right, so this slide at least partially explains the treatment gap in the US. For many of you, it's not unfamiliar, and the complexity of the US reimbursement process is not unfamiliar either. Each of these areas, coding, valuation, coverage policy, payment policy, are not necessarily connected. They are pretty much independent of one another. Coding, CPT codes, ICD codes, HCPCS codes, the whole alphabet soup is done by different entities for different purposes. We're going to be talking about CPT coding today, which is run and owned by the American Medical Association. The valuation process for CPT codes is done through another AMA process called the RUC, the Relative Value Update Committee. They make recommendations to the Centers for Medicare and Medicaid Services on the payment amounts for codes. So the physician work component, as well as the direct practice expense inputs. That is all separate from coverage. So Medicare and commercial payers have their own coverage policies that they can decide on and develop. And then finally, payment policy is also separate from coverage policy. Payment policy is things like code edits, which procedures codes can be done at the same time, which are considered to be included, when it's appropriate to have a multiple procedure reduction, all those types of issues. And then finally, the end of the stream here is provider payment, which we're also going to be talking about today. So next slide. So the U.S. reimbursement system is largely predicated on fee-for-service, although there are obviously alternatives to that you probably all experience. We're largely going to be talking about fee-for-service payment today, and particularly the physician fee schedule for the new TBS codes, and then also the CMS outpatient fee schedule for the hospital outpatient prospective payment system and the APCs that drive that, the ambulatory payment classifications. Private payers will largely adopt many of these systems if they're paying on a fee-for-service basis, and frequently, even if they're not on a fee-for-service basis, if it's per member per month, they frequently it is rolled up into this in some way. So we're going to be talking about that. The DRG system for inpatient payment, I think, is less relative to what we're going to be talking about today. So that's not going to be a topic. Next slide. So these are the 4 new codes for TBS, 77089, 090, 091, and 092. These were developed by the CPT editorial panel. They initially came out in 2022. So they are still relatively new, but they are for trabecular bone score, structural condition of the bone, microarchitecture. And then there are different variations on these. So the first code, the 089, could be considered the global code. It includes the technical work for calculating the TBS score from the DEXA or X-ray data. It also includes physician interpretation on fracture risk. The second code here, the 090, is for a hospital or an imaging center to collect the X-ray or DEXA data and send it out to another center or location where the calculation is going to actually take place. 091 is a code for just the calculation. So it's a center who's receiving the data and just providing the TBS calculation. And finally, the 092 is for the physician review and interpretation only. So this it's understandable that it's complex. It's a little frustrating, perhaps, by some, but the intention here by the CPT editorial panel was to develop codes that can be used in different settings of care, different situations, who has the software, who has the imaging equipment, who's doing the interpretation. In some ways, it's similar to what Dr. Nicola will be talking about in a little bit, which is the professional component, technical component, but it's unfortunately a little more complex than that. Next slide, please. All right, so I hope you all can see these numbers. They're rather small. But we're going to be reviewing the Medicare physician payment associated with each of these codes. And just to note, you might be looking up what you're getting paid in your locality. It's probably different than this. This is the national payment amount, so it's not adjusted by geographic practice indexes. It's just the flat national payment rate. So the first code, which is can be described here as the global code, the payment is $41 based on 0.2 physician work RVUs, a non-facility practice expense RVU of almost 1 of 0.98. And then the conversion factor, which, as you guys are all very much aware, is not in anybody's control, but CMS and potentially the US Congress, comes out to a total amount of $41. And that is for the non-facility or the office-based payment. So the technical code here, the 090, is only $2.71 because that's really just to package the data and send it off electronically, likely. 091 is another technical code. This is the fee for doing the calculation to run the data through the TBS software, the AI engine, if you will, to produce the trabecular bone score, and that's $28.47. And then finally, last but not least, is the physician interpretation. And that comes into almost $10. This is the professional fee for the physician. And you will note here, I think it's important to note in the lower right-hand side that the physician gets paid in the facility as well, obviously. So you can see NAs for the other ones because on the physician fee schedule, the physician, the physician doesn't get paid for these components when it's done in the facility in the hospital because the equipment is owned and paid for by somebody else. But the physician still gets paid for their interpretation, obviously. Next slide, please. So this is the 2023 Medicare hospital outpatient payment. So this is the hospital side of the equation, or the facility side, as it's called on the physician fee schedule. And you can see here that Medicare does not pay for physician work when it's done in the facility. That's done on the physician fee schedule that we just talked about. So the first code, the global code, is not paid, and the bottom code, the 092, is also not paid. Those are the codes that have physician work for the review and interpretation. The two middle codes that are the technical codes, those are paid on the physician fee schedule. And you can see the payment amounts here. They roll up to the APC 5521. And you can say that they're paid, $86.88. Again, that's unadjusted. It's also, I think, important to note that these come with the status indicator S, which means that they are not subject to multiple procedure discounts. So they can be done with other services on the outpatient fee schedule, and the cost will not be taken out. So that's it for me. I think I'm turning it back to you guys. Thank you for your time today.
Thanks so much, Michael, for your detailed presentation. It was really interesting. And we'll now focus on the coding in the real world and the do's and don'ts from Dr. Lauren Nicola. So over to you, Dr. Nicola.
Great, thank you. So Karen did a great job laying the groundwork for what TBS has to offer clinically for our patients. And then Michael gave us a high-level overview of the reimbursement landscape for TBS and what the codes are and what the opportunities are. I'm going to finish up here by talking about, from a practical standpoint, what does this look like for your office? How can you get reimbursed for providing the service to our patients? And what are some do's and don'ts and common problems that we see that result in some denials for payment? So go on to the next slide. Okay, so we're going to start with the fundamental difference between the TBS code family structure and other codes that most office managers are familiar with. And probably the most easy comparison here is the DEXA code. So DEXA and basically all other imaging codes, except for one or two, are structured with modifiers to distinguish between the technical component and the professional component. So DEXA, the code for that is 77080 for the global procedure. And then if you only did the technical component, you would amend that with a modifier TC. If you were only billing for the professional interpretation, the radiologist reading that exam, you would append that with a 26 modifier. And that's how you would tell CMS which one of those services you did and whether you were billing for a technical or professional component reimbursement. So TBS is different, and instead of using modifiers, the code family itself is structured to indicate whether or not the technical or the professional component was performed. The reason the panel did that was to really acknowledge that this is a unique type of procedure, that there's, the software as a service as a kind of as a modality is different than the way that we've commonly provided imaging services in the past. So it's a response to the innovation really that we've seen in this space. So for TBS, as Michael said, the global code, or the what you can consider equivalent to global, is the 8.9 code. So that's if your imaging facility or physician office owns the equipment, performs the service, and interprets the results. So then you would bill the 8.9. If it was the equipment's owned by a hospital outpatient department or a facility in some other way, you would bill the technical component either using the 9.1 or the 9.0. And then separately in the physician fee schedule, the interpreting radiologist or interpreting physician would bill the 9.2 to account for that professional component. So that's different than the modifier scenario that we have for DEXA and other imaging codes. Next slide, please. So what's the difference between the two technical components? There's a 9.1 and a 9.0 code. The difference is that the 9.1 is if your machine has, your DEXA machine, your X-ray machine has the TBS software installed on it. So it's there, it's doing the calculation on site right there for you. The 9.0 was developed for the scenario that you have the machine, but you have to send that data, the raw data, out to some other location for the calculation to be done elsewhere offsite. That's not typically the case scenario that we have now. It could be in the future, but the codes were structured that way to kind of set a precedent for this type of software being valued in the reimbursement system. So for the in most cases, you'll build a 9.1 code. In the rare circumstance that you have to send that data out, then you could use the 9.0 for the technical component. Next slide, please. Okay, so on the left-hand side of the screen here, you'll see the form UB04. That's what you would use for the outpatient prospective payment system. So if you're a hospital outpatient imaging department or facility, then you would use this to bill for the technical component. So this is where you would indicate that the procedure was done. You use those resources to provide the service. On the right-hand side, you see the physician fee schedule form. I think most of these forms are electronic, but they look more or less like this. This is the CMS 1500 form. And this is where you would denote the physician interpretation, the professional component. So the one on the right, you would either use for that global code or for the interpretation only code. The one on the left is what you would use for the technical component of the code. Next slide, please. So as an example, on the left, example A, so if we have a hospital outpatient department that's using split billing, so the TBS exam is performed, the facility is going to bill HOPS using that technical component code. So in most cases, it's the 9.1. They're going to bill that to the outpatient prospective payment system. At the same time, the physician is going to bill the professional fee, the 9.2, to the physician fee schedule. And then those reimbursements will be performed separately in the two different systems. On the right, you see example B. So this is an independent radiology facility, so either a physician-owned office or an IDTF. In that case, the TBS exam is done. The facility does the acquisition of the exam, and the physicians, part of that, that 10 do the interpretation. So you would build a global code. It's all done, all packaged up for you. You build the 8.9 code to the physician fee schedule, and you're all done. Next slide, please. So a couple of coding don'ts. So common mistakes we've seen or errors that have resulted in denials. So the first one is important. So TBS is not mutually exclusive to DEXA. They're not, it doesn't replace DEXA. In fact, they're typically done together and they complement each other. We heard how they complement each other clinically. They also complement each other on from a reimbursement standpoint. So your reimbursement increases for these patients because you can bill the DEXA as well as the TBS. So we expect to see those two together. So don't think that just because you have the DEXA billed, you can't also bill the TBS. They're made to be billed together. The next point here, so just to reinforce here that the DEXA code uses the 2.6 and the TC modifiers to separate the professional and technical components. Unlike DEXA, the TBS codes are structured differently. So you will not append any modifiers to the TBS code. You'll build the codes for technical, or the codes for professional, or the code that has them all bundled together. You will not use any modifiers. And often CMS will see the modifiers and just flat out deny the code because that's not the correct structure to use. And then the last point here, because the 8.9 and 9.2 code include physician interpretation, those do not get billed to the outpatient prospective payment system. Those are billed under the physician fee schedule. It's important to note the difference of those. You would only bill the 9.1 or 9.0 to the ops, and the 8.9 and 9.2, if appropriate, would get billed to the physician fee schedule. Next slide, please. Here we just have an example from one of the MediMap's clients. This is from a radiology center, what the billing claim form actually looks like. So it's kind of small here, but you can see the color-coded circles. At the top there is the diagnosis code, and that's really important. As Michael said, just because you have a code, it doesn't mean that you get payment. You have to indicate that that code was done based on medical, the procedure was done based on medical necessity. So up there you see the M810, indicating the diagnosis of age-related osteoporosis. And then on the next line down, you see the code for DEXA, the 8.0 code. Notice there's to the right, there's a column for modifiers. We don't see any modifiers on this, which is appropriate. And the next slide down is the TBS code. In this case, it's the 8.9, which is that global code. So this radiology center owns their own equipment. They own their DEXA machines. They own the TBS software, and their physicians, their radiologists interpret the scan. It's all billed out at once to the physician fee schedule. So use the 8.9. There's nothing in the modifier category. So this is appropriately how to fill out this claim form and get successful reimbursement. And I think I have one more slide. And this is just to conclude here. This is a map of the United States with the states in bluish, grayish green, showing where TBS was reimbursed by Medicare up through February of 2023. And just remember, these CPT codes were released in January of 2022. So a little over a year into this, we've got a fairly robust coverage. I think that's all I have, and we can hand it back over to Karen.
So thank you for watching, and goodbye from us.